good morning.
Okay, I'm here for the morning shift. Can I get a report? Oh, is he sleeping?
He's sleeping. He's been sleeping.
Okay.
So this is Mr. Mark DeMarcus. He is a 53-year-old gentleman that is 3 days status post lower leg BKA.
Okay, let me just take a look for a sec.
Sure.
No problems?
Yeah, and I haven't taken the dressing off.
Okay, he's still sleeping, huh?
So he was a little bit agitated. He's got a history of being agitated at home.
Okay.
So I gave him some Ativan at about 3 o'clock in the morning, and he's been sleeping since then. So his vital signs, last set was his heart rate was 100, blood pressure was 105/65, respiratory rate was 20, and his temperature was 37.4. So he's got a history of diabetes, coronary artery disease, COPD, hypertension. He's not on any IV pain medications anymore. They DC'd his PCA before they transferred him out of the ICU. He does have just a PRN adapter in his right arm.
Sounds good. So what's on the schedule for today, did you say?
So he's got physical therapy that's supposed to come to see him at 9.
Okay.
That's the only really thing that I know he's doing, and I think it's his first physical therapy appointment.
And you said he was kind of agitated in the night. Is that normal for him?
Yeah, that's what I got in report, is that it's kind of normal for him. He takes Ativan at home, so I gave him 4 milligrams of Ativan tonight.
Okay, sounds good. You have a good day.
Thanks.
Going to yoga?
I'm going to that yoga class you told me about. Thank you.
All right, I'm going to do some vitals now.
All right, here's a sheet in case you need it.
I'm going to try to be quiet with you for a minute. So, Mark, hey, are you going to wake up for me? Okay. I'll put your blood pressure. Oh, are you having some pain? You feel a little bit warm. Okay, we're going to take your blood pressure. You're going to feel that a little bit tight there. Okay. I'm going to take your temperature too. You're a little bit warm. Can you wake up for me? Mr. Mark DeMarcus. I need a rapid response team, please. Can you call that?
Rapid response
Mark, can you wake up
team,
for
Ward
me,
3C,
please?
room 321. Rapid response
Mark, wake
team,
up for
Ward
me.
3C, room 321.
Where is my nasal prong? Oh gosh. Mark, wake up for me, please. Come on. Hey, I called a rapid response team.
I'm Shelley, the nurse.
Shelley.
I'm Daniel.
Daniel, who's the team leader?
Yes, can you, thanks for calling Rapid Response.
Okay.
Yeah.
Respiratory therapy.
Okay, awesome. Hey, Mark, can you wake up? So this is Mr. Mark DeMarcus. I literally just got report. I don't know a lot about him. He is, just came to us yesterday. He is day 3 post-op for a left lower leg BKA. I guess he was agitated overnight, but has a history of it. They gave him some Ativan, last pain meds on board at 0300. But he's just not really waking up for me right now. And blood pressure, that's his last blood pressure right there, is quite low, and he's starting to get a bit tachycardic. He feels warm. So at this point, he does have one IV. I'm looking to see if we can put like nasal prong oxygen.
Okay.
Does that sound good? What can I do to help you guys?
And hand wash here?
Hand wash, we did have, on the outside, and there's gloves over here. Hey, Mark, we've got some people here to help you.
Some gloves?
Mark, my name is Daniel.
Thank you.
I'm one of the nurses here. Shelley, you want to grab me a sec, please? Mark, are you having trouble breathing?
He goes by Mark. His name is Mr. Mark DeMarcus.
Do you want to put an O2 on him?
I will put O2 on him. Here, there's this stethoscope.
You want to?
Okay, I'm going to get in here.
Hello, Mr. Marquez. My name is Edgar Herrera. How are you today?
Do you want a non-rebreather?
Mr. Marquez? That's a response.
I'd rather prefer that if I could.
All right, heart rate 96, sat of 92, BP of 89/48. Can we cycle the cuff again?
Sure, we'll cycle the cuff one more time for you. Do you want it cycling every 2 minutes? Or?
Yeah, for now.
Breather mask
Okay.
Yes, please. Okay. Connect it.
Okay, it's going to cycle every 2 minutes.
Oxygen, please. 6 liters it is.
Mr. Marcus?
He wouldn't really wake up for me.
What time did you receive the Ativan?
So per my report, let me look at my report. My goodness, I've got a chart for him as well. So, what did she tell me? She was rushing out of here. Okay, at 0300 he had Ativan 4 milligrams. Okay. So I guess that's normal for him to use that. And he had a pain med at 0200.
What was
He's
the
on
pain med?
he's on oral pain meds. Let me pull up his chart.
Okay.
Your pulse
What do you need?
is-
Any medication?
That could be good.
Does that sound okay?
Yep.
He is a full code. 53. I can give you history and physical if you
Heart
want.
sounds without problems.
Okay, all right.
Let me
Is
check
the
pulse.
oxygen helping his sats?
He has a history of diabetes as well, and they've been giving him some insulin. The last one was actually 2 days ago.
Should we check
Pain
it?
meds, oxycodone with acetaminophen, 5
Well, I
milligrams.
response.
Okay, all right.
Should we check a sat or check
And
The SAT?
glucose?
All right, SAT has responded to the oxygen.
We could, I know the ICU nurses,
Mr.
I think you
Marquez,
guys
I'm
carry
gonna-
the iStat, so you could
And-
run.
Yes.
Okay.
Okay.
Expose your chest. Let me see.
Is the eye still
Can I
here?
see something on the chest of
No,
the patient?
he looks good, everything looks fine, he's kind of cool to
Intercostal
touch, yeah.
muscles, anything?
Okay.
Okay.
I don't
I'm
see
going
any.
to check a blood sugar. Is there a blood sugar here?
Blood sugar is
Blood.
110.
Okay.
Okay, all right.
We recheck a temperature?
Sinusal, okay.
Recheck the temperature, sure, I can do that for you. Has a history of
Did we get lung
COPD.
Did we get
Okay.
lung sounds?
I don't know if he's
Really?
You
we listen to lung
auscultated the
sounds?
lungs?
Yes, I
Yeah.
did.
I believe,
Sounds good.
I can
But no,
see him
then
breathing.
listen again.
Temperature is 101.5. Do we want to start some IV fluids?
That's a good idea.
Do you guys want IV fluids?
Yeah, let's run through that.
Correct.
Okay, so we got the
Upper right, correct.
What else are we thinking? What should we do?
Lower right, correct.
And
Yep.
recent CVC.
I'll pull up his recent CBC.
This is a blood tubing.
Seems like he's got a temperature. Could he have an
Yeah,
infection?
I see that.
That's-
Yes.
Lower
And sepsis
correct.
is a concern.
Everything clear? All right.
Okay, so I did
gonna
learn
use
if
like
we
the
have
double-
sepsis, we've got to start our bundle. This is his latest.
Okay,
That was drawn yesterday morning.
okay. White count of 2.2.
Sputum 92, okay. So,
All right, grid of 39.
Okay, good, we've got that.
Okay. We don't have, let's run a lactate on him too. Oh,
Yeah.
just run another chem panel
Okay.
with lactate.
I'm going to turn his oxygen up, doctor, if that's okay. We're at
Is
6
he-
liters. He's
is
still
he-
a sat and a little low,
okay,
if you know.
all right.
He
So
is.
let's go to 10.
Respiratory rate?
Is that okay?
excuse me?
10 liters per minute?
10 liters per minute is correct.
10 liters?
Thank you.
Any change in respiratory rate or pattern?
He looks tired, is he?
His respiratory rate's still about 24.
He is,
Okay.
and he's still breathing at 92.
All right.
His heart rate is
So-
really going fast, so we've got fluids running on him. Okay,
let's
that's
see.
good.
skin
All right, so
hot.
where's-
Let's
Yeah,
go
he's
down
really
to
warm.
Okay, fluids
so
going.
there's sepsis.
Okay, so we've sent all our labs. What else would we like?
Oh, here's lactate.
Mr.
Mr.
DeMarcus,
Marcus?
Yes.
All right.
can you wake up a little bit for us?
What's the latest blood
Okay.
pressure?
9150 just cycled.
Okay. And so I can have pharmacy send the antibiotics per our sepsis protocol?
What? Yes, let's do that. yeah.
Okay, and you sent off all of the labs?
Lab sent.
Okay, good. And the troponin was within normal limits?
So our presumptive diagnosis is early stage of sepsis right now, as opposed to
Okay.
PKA?
So I don't think we can keep him here on this unit,
Yeah, so he needs to be transferred to the unit.
so.
indoor
Okay.
at the ICU.
Maybe can you call and see if they've got a bed
Okay.
in
I
the
will call.
ICU or
ICU, I think,
okay, in the ICU. Let's see, because I know we're full, we cannot.
of course.
Okay. I'll get him ready to transport.
All right.
Yep. I'm going to hook him up to the monitor.
All right.
All right. Okay, guys, that's a wrap. We're going to go over now. All we need to do is make sure oxygen is turned off and turn off any IV fluids. Gloves on the side. We're going to grab a chair and go over to debrief.
Okay.
So any initial reactions from you guys?
I can say that you feel a little bit helpless at first, trying to figure out what the thing that's happening with the patient. Thinking about going through an assessment and looking at the different systems. appreciating my team members for their insights.
Yeah, it's stressful in many ways, including the fact that we're an ad hoc team. We did meet yesterday briefly.
Briefly, very
So we
briefly.
at least know each other's names.
Yeah.
Well, it's the first time I do this work in English. My native language is Spanish, so it's a little complicated to do this, but and it's the first time that I work with all these doctors, so it has been a great experience. I feel a little confused about the mannequin sounds because I was not sure if what I was listening was the real sound I was expecting or something of the mannequin, and I was afraid to ask if this was a
Right.
problem with the patient.
And that's a great point to come up because, you know, even in the clinical environment, when we do this in situ, or I'm sorry, I'm from the Midwest, I say in situ. My boss tells me to say in situ, but you know. When you do this in the clinical setting, it's hard to hear those sounds sometimes. It's hard to hear those sounds sometimes on a real patient. So, you know, these are things that we encounter and we can say, I think they're clear. Do you want to take a listen again, right?
Yeah, and I did hear you verbalize that I'm not sure, I think this is what I'm hearing. And that's the same thing with a real patient that we want to communicate with our team. So, all right.
Great. So, one of the things I want to talk about is the leadership, because I think it was really interesting because Cynthia asked at one point, like, who's the leader of the team? And again, we know this is an ad hoc team and you've all discussed some of the challenges of that. But I want to kind of like hear your impressions and thoughts about how you kind of manage that leadership.
Yeah, here we did have assigned roles. We didn't really discuss what those assigned roles really comprised. So that was a little bit of a handicap. I don't know if we introduced ourselves adequately during the scenario.
How does it work in real life if you enter into a patient's room and you're called there? How do you determine who is who?
It's hard sometimes.
Yeah.
It actually is because the codes I've gone to, sometimes people do not explicitly say what their role is, and perhaps they don't really know what their role is.
Right, and I think one of the things that we found when doing this is practice like this is a great opportunity to kind of find those system issues like, hey, do we know what we have assigned roles and is the ED doc in charge, or is the anesthesia just doing airway, or is the anesthesiologist in charge and who's doing airway and who's doing meds? And so having these practice scenarios gives us real opportunities to think about the way we run these and to think about, okay, maybe we need to go back and I need to talk to my team and say, if this happens, what do I do?
Yeah, and I'm wondering, Kelly, as the respiratory therapy, I mean, what I've observed is that typically respiratory therapy comes in and they go to the head and grab airway, and that's one of the signs for me. But that's probably respiratory therapy. Was there a moment with the team, did you know who the team leader was, or how do you usually do that?
I heard both of the physicians introduce themselves.
Okay.
But again, just made assumptions based on my other partners here as well. And I don't think when I stepped into the room that I probably made my announcement loud enough, although I did say respiratory Kelly, but I was maybe a little too quiet on the draw.
And as the nurse is entering the scene?
Yeah, I think the introductions, I introduced myself to you, but I didn't introduce myself to the other team members.
And you did a really nice job too of introducing yourself to the patient too, so.
Yeah, actually I thought that was one of the things we're focusing on in the hospitals now is patient-centered care, and even if our patient is moaning, still being inclusive with them, so appreciate that from you. Okay.
Yeah, and so when you guys were kind of determining what was going on, I saw you looking at the chart, and I heard Cynthia asking kind of like, what do you think were going on? What were your impressions or what were your thoughts of what might be possibilities with the patient at that time?
I was looking for our CRM.
What?
I was looking for our CRM, which is our crisis resource management. We've talked about these principles. We'll show them to you later.
Well, my first, when I first got in, I thought it was more of maybe too much Ativan. That was my initial assessment of the situation. And then when you described more of the temperature, blood pressure, and what he came in with, that kind of clued me into something else. So.
I didn't hear you say too much Ativan. Was that anything that was verbalized out loud or to the team leader?
I did not say it.
Oh, what are some of the barriers with team members of stating what their mental model is out loud?
Well, I think as a, if one, you don't know if you're right. So I think if you say something that's completely off, that could be a little scary, depending on where you are. But I don't know why I didn't say it. I just kind of just didn't.
Yeah. One of the fascinating concepts, if we had a huge lot of time to debrief this, is this concept of we are really good in healthcare about rewarding people for picking up the things that they do, the good catches, but we're not necessarily good about rewarding the people for the things that they verbalize that aren't necessarily true. So it's like, oh, if you would have said it, it would have been a shared mental model, as Cynthia says, but it's like, then everybody could have said, oh, let's think about those differential diagnoses. Yes, it could be this, it could be that. So it's a way of sharing that. But we're not, as a profession or a group of professions, really good about recognizing and rewarding those opportunities, I think.
Right. Were there any of the other team members that had the thought of perhaps that there was too much medication on board?
Yeah, well, being an anesthesiologist, yeah, that's what I'm
That's a default.
that.
Right.
So that would have been, that's why I asked about what pain medication he got.
True, yeah, and I had to go look that up for you.
And the Ativan is long acting, but he's on that chronically, or at least during his hospital stay.
Okay.
And I didn't stay with that. I saw his respiratory rate was relatively high. His chest rise was good. 24 respirs per minute usually isn't conducive to an Ativan overdose and such. So I didn't stay there with that, to be honest with you. I felt where he was in terms of his respiratory rate and his temperature was pointing much more towards sepsis, but I did not verbalize it at all.
So this is an interesting kind of little micro role play, because Daniel, if you would have said, hey, I'm thinking about too much medication, what are your thoughts? Kelly could have said, oh, here's what I'm thinking, and it would have taken a short amount of time to have that exposed to the whole team then. So these are things that we hope to uncover when we're having these conversations like this.
And Shelley, you being the second nurse?
Well, my concern was his neurological status, but I didn't know what his baseline was. And he was just moaning, but he had a rapid respiratory rate, and there was a hint about a little bit of a fever. So I wanted to kind of stay with that and figure out what is his neural status. Nice neuro checks, I noticed assessment on that. And I was just kind of standing back a little bit and just kind of wanting to do a reassessment of where we were to try to figure out what the problem was.
Okay.
That was my thought.
Now, I was watching from the front row, so I'm going to excuse myself. I heard Cynthia say something about the sepsis bundle, but I didn't hear if anybody else said something first.
So to be clear, I was part of this scenario, so there was some queuing.
Yeah.
But that was one of the things. So when we heard sepsis bundle, Glenn, I heard you then say, yes.
Yes.
We do. And people are familiar with the sepsis bundles?
Not really. Yeah, I know it's there, but I've never used it.
So if you weren't familiar, what might be some of the resources? And Shelley, do you know?
I really can't answer that question.
Okay.
I'm not sure.
Any of the other team members? So actually, floor nurses are probably one of your better resources because they get a lot of training and they can generally pull them up on the electronic health record. So again, that's using all available information and planning and preparing. And there's actually a very discrete timeline of getting medications in. We didn't have pharmacy with us, so activating pharmacy to get antibiotics would be very important. Gotcha. So, yes.
Yeah, the sepsis bundle is a big, another big discussion point that if we had a lot of time, we'd spend time, but I'm looking that Cynthia's giving me the sign that we're a little close to time. So,
we are. We've got just about half a minute, 1 minute to kind of wrap up.
As the therapist says, our time is coming to an end. Does anybody have any burning issues before we wrap it up?
No?
It was a good experience for us. As,
oh, good. You preempted my next question. Is what are you coming away from with this?
Right. Well, we do run these simulations sometimes on an announced. This was an unannounced to you today. You've been through simulations before with us, so we didn't have the luxury of pre-briefing you, but we want you to know that we do respect that this is a training environment. This is not for testing. The information that goes back to any of your management or superiors is truly just about what type of scenario, what were the objectives, and we may do general observations. For example, if we found a system issue or a piece of information like that, but there is no individual. We call it kind of our Vegas rules.
That applies to all you guys too.
That's right. We always want to thank you for your time. We recognize that the work that you do every day is hard. And we challenge you in the simulation scenarios because we really feel that they should be equal to the type of work that you do. So.
Thank you for the opportunity.
Thank you.
Thank you very much.
Thank you. So, can I have you stay?
Yeah.
We want to take a few minutes and just have them introduce themselves because they were truly volunteers that I solicited through email, randomly picked some people to ask them if they'd love to participate in this scenario. All that they knew is that they were providers in their real role at an acute care hospital and were going to be responding to a rapid response. They had no idea about the patient or the scenario until they came into it this morning. So if there was any kind of thoughts of why didn't they do this, they had no idea. And that was part of it, to have the authenticity. So I'm going to have them introduce themselves, and then they're going to go and we will do our presentation and deconstruct the scenario that we just did.
Glenn Hoshizaki, I'm an anesthesiologist at the VA Greater Los Angeles.
Edgar Herrera, emergency medicine.
Daniel Kampugan, clinical educator for Kaiser Permanente.
Michelle Shelley Salakian. I am faculty at Cal State Channel Islands in the Sim Lab, but training is as a PNP.
Kelly McKeever, Laerdal. I am not a respiratory therapist.
No. Well, we thank you guys very much. They're going to go back and we're going to do a presentation for you.